Okay, my friends, my name is Dr. Said Kazmi. You're watching my YouTube channel, and let's talk about platelet disorders in pediatric practice. Many times you would come across when you are with a situation in which you would be suspecting platelet disorders. It might be the scenario in which you find a child who has got a history of mucocutaneous bleeding, or he has presented with a generalized non-blanching petechial rash on his torso, or maybe you have done a workup for something, you have done a full blood count, and on the full blood count picture you have found that the platelet count is low, or maybe the smear has given you some information that the platelet morphology is abnormal. For example, there are small platelets or there are large platelets, or the mean platelet volume is either small or large. So you can come across a variety of scenarios in which you might think that there is something wrong with the platelets. So in this particular lecture, we are going to take a structured approach to evaluate these kids who have got some form of platelet disorders. So without further ado, let's dive in and get started. So whenever you are suspecting, let's say on the base of the history or on the base of presentation, the first step is to do your initial evaluation, and your initial evaluation is always taking a blood sample and checking what we call as a full blood count or a complete blood count, and that should be supplemented by a peripheral blood smear. So peripheral blood smear is actually in which a slide is prepared and the hematologist examine that slide under the microscope to see what is the morphology of the cell. At the same time, you also on the basis of your history and clinical assessment, you determine whether there is a history of superficial bleeding in the form of like a generalized petechial rash, or mucosal bleeding like epistaxis, or bleeding from the mouth, or is there a deep tissue bleeding in the form of swollen joints like hemarthrosis, or there are deep-seated hematomas because of, let's say, as a complication of intramuscular injections or things like that, where you would be suspecting more of a coagulation factor defect. So by and large, keep it in mind that based on your clinical assessment, usually platelet disorders, they present with superficial bleeding. So there's usually a history of mucocutaneous bleeding, while in case of in case of coagulation factor disorders, they are usually a history of deep-seated bleeding in the form of hematomas or in the form of bleeding into the joints. So the first step is that you have to take a blood sample and do what we call as a full blood count and look at the smear. Now, let's say the full blood count picture is in front of you, and you've got two like scenarios related to platelet in front of you. One thing could be that the platelet count is low. So the normal platelet count is 150 to 450,000 per microliter. That is a normal platelet count. And if the platelet count is reduced, that means if it is less than 150,000 per microliter, we call it as thrombocytopenia or a low platelet count. If it is within the normal limit, then again, that would be a normal platelet count. So just first step is to see the platelet count, whether it's low or whether it's normal. So first of all, let's talk about if the platelet count is low, what we would do. So if the platelet count is low, let's say the platelet count is less than 150,000 per microliter, this is what we call as thrombocytopenia. So the platelet count is low. It means that there is some form of thrombocytopenia. Now, there could be two scenarios here. One is that it is an actual true thrombocytopenia. What does that mean? That in fact the platelet count is on the lower side. The second possibility is that what you are seeing is a spurious thrombocytopenia. That means that the platelets in fact are not less in the blood, but what has happened that during the blood testing the platelets were clumped together, and because of that clumping together, the way these machines they count the platelet, they have counted them to be on the lower side. So if the clumping is present, we call it as pseudothrombocytopenia. And for pseudothrombocytopenia, remember, we have to repeat the full blood count, and this time we have to use the citrate tube. So if you suspect that this is a pseudothrombocytopenia, that there is no actual decrease in platelet count, but this is because of the clumping, or maybe the smear shows that, then you have to recheck the blood doing full blood count in a citrate tube or doing platelet count in a citrate tube. So this is very, very important. The first step is to see whether it's true thrombocytopenia or whether it's pseudothrombocytopenia. Now, if it is true thrombocytopenia, the actual platelet count is low. It's less than 150,000 per microliter. Now, the next step is to see if the other cell lines are also affected or not. Because if thrombocytopenia is associated with a lower red blood cell count, or if is associated with a lower white blood cell count, then it means that the other cell lines are also affected. And if the other cell lines are also affected, then you are looking at a broader hematological problem. It might be a case of leukemia, it might be a case of aplastic anemia, it might be a case of myelodysplastic syndrome. So it's important that if somebody presents with thrombocytopenia and they have got other cell lines on the lower side as well, like for example a low white blood cell count and a low red blood cell count, you should take that very seriously, because you are dealing with some serious underlying hematological problem. These kids, they always need a bone marrow examination, because bone marrow would determine whether it is a case of aplastic anemia or whether it's a case of leukemia. The difference is that in aplastic anemia, because everything is depressed, usually what you get is a hypocellular bone marrow. While in case of leukemia, because there are abnormal cells, what you normally get on bone marrow examination is a hypercellular bone marrow. So if thrombocytopenia is associated with pancytopenia, always go for bone marrow biopsy, because bone marrow biopsy is going to differentiate whether this is aplastic anemia or whether this is leukemia or some other form of myelodysplastic syndrome. Now, if there are no cytopenias, but let's say with thrombocytopenia there are signs of anemia or the hemoglobin is low, the white blood cell count is fine, the RBC count is fine, but it's just that the hemoglobin is on the lower side, then it's important that you have to do certain tests to rule out certain forms of hemolytic anemia. So what test you order if you see a child who has got low platelet count and has got low hemoglobin? You would order lactate dehydrogenase, you will check for haptoglobin levels, you will check for bilirubin levels, and you will also see if there are schistocytes on these peripheral smear or not. Because if there is hemolysis, for any reason the RBCs are getting broken down, so what would happen? You will be having an increase in lactate dehydrogenase, while there would be a corresponding decrease in haptoglobin as well, and the bilirubin would be on the higher side with more of the indirect bilirubin because of the breakdown of hemoglobin. So if you have got hemolytic anemia with thrombocytopenia, then you should be thinking of certain types of disorders, like for example hemolytic uremic syndrome, thrombotic thrombocytopenia, or disseminated intravascular coagulation, which is usually a sort of a sequelae of full-blown sepsis. So if a child has got anemia with thrombocytopenia and the bilirubin and the LDH are raised, you should be thinking of what we call as microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia means that there is some cause inside the blood vessels which is causing destruction of the platelets. So usually what happens is that because of different reasons like thrombotic thrombocytopenia or hemolytic uremic syndrome, there are small thromboids form within the small vessels, and as the platelets they cross these small thrombi, they act like as knife, so they just like break down the platelets are broken down shearing because of the shearing forces, and when the platelets are broken down you get low platelet count. So there are three conditions, important conditions, in which you would be getting anemia with low platelet count, and that is hemolytic uremic syndrome, thrombotic thrombocytopenia purpura, and disseminated intravascular coagulation. Now, how do you differentiate these three? Now, DIC usually is a very sick child, for example, usually with sepsis, and the coagulation profile is always deranged. So if you do a PT, APTT, you would see that the PT and APTT both are prolonged with a decrease in fibrinogen and increase in D-dimer. So that is associated with a problem in the coagulation profile as well. So with platelets, if the coagulation profile is also deranged, you always think of disseminated intravascular coagulation. But if there is a normal coagulation profile and you've got platelet count which is reduced and you've got signs of anemia, then you are dealing either with hemolytic uremic syndrome or TTP. Now, thrombotic thrombocytopenia purpura, basically you've got fever, you've got neurological signs, and you've got renal failure, and you've got signs of low platelet count. usually how you differentiate it from hemolytic uremic syndrome, because they are more or less on the same spectrum. The only one thing is that in thrombotic thrombocytopenia purpura, you always have got reduced ADAMTS13 activity in the blood, which is always and always normal in hemolytic uremic syndrome. So for example point of view, if somebody asks you what is the best test to differentiate between hemolytic uremic syndrome and thrombotic thrombocytopenia purpura, remember your answer should be ADAMS TS13, because ADAM TS13 is reduced in thrombotic thrombocytopenia purpura but normal in hemolytic uremic syndrome. And hemolytic uremic syndrome usually occurs after some form of bacillary dysentery, and these kids they develop renal failure along with low platelet count and anemia. So the important thing, remember, in hemolytic uremic syndrome is never ever give them antibiotics, because the more you give antibiotics, there will be more bacterial breakdown, and that's gonna just aggravate the whole scenario. So we'll come to the treatment maybe in the later stages of this lecture. But remember, any child who's got low platelet count and has got anemia with it, you should be thinking of DIC, disseminated intravascular coagulation, or thrombotic thrombocytopenia purpura, or what? Hemolytic uremic syndrome. So remember, in DIC the coagulation profile is always deranged while it is normal in the other two. And for the other two, remember to differentiate between HUS and TTP. The best test is ADAM TS13. Okay, so if anemia and thrombocytopenia, that condition is not present, and you are only dealing with isolated thrombocytopenia, it means just the platelet count is low but white blood cell count is normal, RBC cell is count, and hemoglobin is normal, and you have just only this one abnormality in the full blood count, that is low platelet, then you are dealing with what we call as isolated thrombocytopenia. Now, isolated thrombocytopenia is interesting because many people straight away start thinking of idiopathic thrombocytopenia purpura or immune thrombocytopenia purpura. Now, that is what we call a diagnosis of exclusion. You have to make sure that there are no other reasons for causing an isolated low platelet count. So remember, if a child who has got isolated thrombocytopenia, you have to make sure that number one, he is not on heparin, because sometimes heparin induced thrombocytopenia can occur, though normally in pediatric practice you would rarely come across somebody who is on heparin. It's mostly the adult patients where you would see that. So probably I would not discuss that in detail. Yes, in teenagers, if they've got a history of miscarriages and repeated thrombosis or DVT, let's say, or there's a family history of SLE, then you should be thinking of antiphospholipid syndrome, because antiphospholipid syndrome can also cause isolated thrombocytopenia. Also, certain types of infections like HIV, hepatitis C vaccine, certain types of drugs and malignancy, they can also cause an isolated reduction in platelet count, which we call as secondary immune thrombocytopenia purpura. So it's important to ask or try to find out if the child who has got isolated thrombocytopenia, whether he has got a history of HIV, HCV, or using certain type of drugs which might cause thrombocytopenia. You have to make sure that you are ruling them out, because once you have ruled out all these conditions and you are left with no answer, then primarily you are dealing what we call as primary ITP, or primary immune thrombocytopenia purpura. So primary immune thrombocytopenia purpura is a diagnosis of exclusion. So remember, whenever you get an isolated thrombocytopenia, and I know you would definitely get it in your practice, you have to ensure at that point that the child is not having any underlying conditions which would cause thrombocytopenia. For example, has there been a history of certain types of drugs like sulfur drugs? Is there any hidden malignancy or any history of any cancer? You have to rule out if the child is suffering from hepatitis C or HIV, or is suffering from certain types of immune disorders like SLE, in which, or even other types of immune what you call disorders, inflammatory disorders, in which the ANA can be positive. So you have to rule out a few conditions, and once you have ruled it out, then you are left with what we call as primary immune thrombocytopenia purpura. So remember, you always start with looking at the other blood cell lines. Okay, so if there is a history of, or if let's say on the full blood count you find low RBC count, low WBC count, then you should be thinking of some hematological problems. In all those cases, they require bone marrow testing, and then again on the basis of bone marrow testing, you would decide whether this is a aplastic anemia or some form of malignancy. If it is associated with anemia, then you have to think of microangiopathic hemolytic anemias, and obviously you have to do a coagulation profile, and you have to see if the child is suffering from hemolytic uremic syndrome or thrombotic thrombocytopenia purpura. So how do you treat these conditions? Some of these conditions: number one, if you are talking about let's say bone marrow aplastic anemia or leukemias, then they have to be treated in a specialized manner by the hematologists in specialized centers, because they might require certain type of anti-cancer therapy, or they might require bone marrow transplantation, or they might require certain types of biologicals. So that always has to be done in a very specialized center. For thrombotic thrombocytopenia purpura and hemolytic uremic syndrome. Now, for hemolytic uremic syndrome, all we do is to give supportive treatment. The key here is to not give them antibiotics, because if antibiotics are given, what would happen? That would sort of suddenly kill all the bacteria, and these bacterial antigens, which is actually causing this immune mediated problem inside the blood vessels, that would just aggravate and the child can die. So usually it is treated with fluids and conservative treatment till the condition resolves. So let's say if the child is going into frank renal failure, then obviously you can think of the renal replacement therapy, but other than that, they usually require fluid therapy. And that is, yes, about thrombotic thrombocytopenia purpura, because it's more dangerous than the hemolytic uremic syndrome, usually it is treated with plasma exchange and steroids. So usually plasmas and steroids, because if there is a dangerously low level of Adams TS13, you have to sort of exchange the plasma so that the levels, they go back up to the normal, and you might have to give steroids to calm down the sort of the immune flare up as well. I don't want to go into the treatment of heparin induced thrombocytopenia, because it's rarely seen in children. It's mostly a problem of the adults. And as far as the immune thrombocytopenia purpura is concerned, for immune thrombocytopenia purpura, usually it depends on how low the platelet count is. If the platelet count is mildly reduced, we just do serial bloods, and we just follow them up. We just keep them under the radar screen. Yes, if it falls below a critical level, like for example less than 30,000 or less than 10,000, then there are chances of internal bleeding or something. In that particular case, then we have to treat them with intravenous immunoglobulin, which is very good in that, or steroids. We normally don't give them the what you call the platelet transfusions, because it's an immune mediated problem. So the more platelets you give them, they would be destroyed, and that would just lead to aggravation of the whole condition. So we usually treat idiopathic thrombocytopenia purpura if it needs to be treated. Remember, most of them would just sort of resolve on their own. But let's say if it is still sort of persist beyond 3 months, then usually you have to start treatment. Or if the levels are considerably falling down over a period of time, then you might have to treat them with intravenous immunoglobulins plus minus steroids. And if that is not working, then we've got the biologicals, and rituximab is one of the biologicals which is used for treating immune thrombocytopenia purpura, which is not responding to the first line medications like IVIG and steroids. And in case if the idiopathic thrombocytopenia purpura becomes a chronic one, that is, if it persists beyond 12 months, then usually the treatment is doing splenectomy. Though splenectomy is a very radical procedure, and these kids then have to be put on some form of antibiotic prophylaxis for the rest of their life, and make sure that they are immunized against encapsulated organisms. So this is how you go on that pathway if the platelet count is reduced. Now, what if you think that there is some platelet disorder, because there's either mucocutaneous bleeding or epistaxis or something, but the platelet count is normal? Then probably you are dealing with what we call as platelet dysfunction. So what happens in platelet dysfunction? The important thing here is to check for bleeding time, because the bleeding time, if it is increased with a normal platelet count, then you are dealing with platelet dysfunction. So if there is normal platelet count and the bleeding time is increased, you are dealing with what? With platelet dysfunction. Now, the first thing is to make sure that you have to take a good history to see if the child is on any medication which is considered to be an antiplatelet. For example, is the child on aspirin? For example, some kids may be on aspirin because of Kawasaki disease, or some might be on clopidogrel. So you have to ask, because these medications are antiplatelet, they can cause uh, sort of issues with the platelets, like they can increase the bleeding time and they can cause mucocutaneous bleeding despite the fact that the platelet count would be normal. Then certain kids who have got renal failure, because of chronic renal failure, the urea levels, they rise, and we call it uremic platelet dysfunction. So uremic platelet dysfunction, the high levels of urea actually cause problems with platelet addition to one another. So what happens if the urea levels are high, the platelets are not able to sort of stick together with one another, and if they are not able to stick together, then obviously because of the micro traumas here and there, these kids can have tendency to bleed. Or if there is a family history of bleeding, then these kids might be having some form of platelet uh, qualitative platelet disorder, which has been transmitted from one generation to the other generation. So the first step is to taking a good history and to see if there are any reasons that the platelet might not be able to function properly. That is in the form of any medication, or if there is not a medication, is there any chronic condition which might be causing that, or is there any family history. Let's say if it is none, then what you would do is you would do what we call as ristocetin cofactor assay. Basically, we are looking for a condition which is known as von Willebrand disease. So in von Willebrand disease, there is a history of it's an autosomal dominant condition. Is usually passed from one generation to the other generation, and there is history of mucocutaneous bleeding, mostly epistaxis. And if you do the ristocetin cofactor assay, you would see that there is a decrease in the von Willebrand antigen and the von Willebrand factor activity. Basically, when you are doing the ristocetin cofactor assays or the von Willebrand assays, you are basically looking at the von Willebrand antigen, the Willebrand activity, and the factor 8, which again can be low, and that on the basis of that you can classify different types of von Willebrand factor disease, whether it's a type 1, type 2, or type 3. Anyhow, for sake of simplicity, if the ristocetin cofactor assay is reduced, then either you are dealing with von Willebrand disease or you are dealing with Bernard-Soulier syndrome. Either you're dealing with what? Von Willebrand disease or Bernard-Soulier syndrome. The only difference is that Bernard-Soulier syndrome would show you large platelets. So usually on the peripheral smear, you will see there are large platelets. If you've got normal assay, the ristocetin cofactor assay comes out to be normal. So then you have to go for platelet aggregation studies, because there are other types of platelet disorders, like for example Glanzmann thrombasthenia, which might be causing this qualitative platelet deficiency. So you have to do then platelet aggregation studies. These are advanced diagnostic tests, and again based on that you can actually determine if the child has got von Willebrand disease, whether this child has got Bernard-Soulier syndrome, or whether this child has got Glanzmann thrombocytopenia. Because remember, in von Willebrand disease, which is the most common of all these, there is a reduced von Willebrand activity. And how do we know? We do the von Willebrand assays, and you see a reduction in the von Willebrand antigen and a decreased factor 8. So these kids, they present with repeated mucocutaneous bleeding, usually epistaxis. In Bernard-Soulier syndrome, what would happen is that there is the reduction in the glycoprotein 1b receptor. So what happened? The platelets are not able to sort of stick to one another, and usually in this condition on the special smear you see giant platelets. So there are very large size platelets, which should point towards, if somebody has got history of mucocutaneous bleeding and the platelet count is normal but the platelets are large in size, then you should be thinking of Bernard-Soulier syndrome. And if the platelet count is normal and the platelet volume is also normal, von Willebrand assays are normal, but the platelet aggregation study shows that there is a reduction in the glycoprotein 2b or 3 alpha. 2 beta or 3 alpha. Both of them can be, one of them or both of them can be on the lower side. So then you are dealing what we call as Glanzmann thrombocytopenia. We call it what? Glanzmann thrombocytopenia. So these are qualitative platelet disorders. They are usually treated with either desmopressin, or if let's say there is chronic renal failure, you will have to go for dialysis or some form of renal placement therapy. But usually desmopressin in certain types of von Willebrand disease, in certain types of Bernard-Soulier syndrome and Glanzmann thrombocytopenia can cause a sort of a resolution of the symptomatology of the child. So just to summarize all this, to give you the whole thing in a nutshell, remember, if you are suspecting platelet disorder because of repeated history of repeated mucocutaneous bleeding, or because you found that the platelet counts are low, remember the first step is to see if the platelet count is low, whether it is pseudothrombocytopenia or true thrombocytopenia. If it is pseudothrombocytopenia, obviously you just repeat the test in a citrate bottle and you don't need to treat it. If it is true thrombocytopenia, you have to see whether the other cell lines are affected or not. If the other cell line is affected, their problem is in the bone marrow in the form of either aplastic anemia or maybe some form of leukemia, myelodysplastic syndrome. If the other cell lines are fine, you have to see if the child has got low hemoglobin or signs of anemia or not. So if there is thrombocytopenia with anemia, remember, you always check for LDH, you check for haptoglobin, you check for bilirubin. So if there is increase in LDH and bilirubin, you are dealing with the hemolytic anemias. And remember, with that, the first thing is to do a coagulation profile, because the coagulation profile range, you are dealing with disseminated intravascular coagulation. If that is normal, you might be dealing with hemolytic uremic syndrome or thrombotic thrombocytopenia purpura, in which the key differentiating test is ADAM-TS13 levels, which would be reduced in TTP but normal in HUS. And if everything is fine, you are just dealing with the isolated thrombocytopenia, then you are dealing with what an isolated thrombocytopenia, which might be primary or secondary. Secondary is usually secondary to drugs, secondary to certain types of infection like hepatitis C or HIV or chronic sometimes renal failure. So in that particular case, you have to treat the underlying condition. But if all the conditions have been ruled out, then you are dealing with what we call as primary immune thrombocytopenia purpura, which is usually treated based on how low the platelet count is. Most of the time we just follow them up with serial platelet counts to see if they are stable, if they are coming back, or if they are sort of deteriorating. If it goes beyond 3 months, or if the levels are persistently falling, then you can treat it with IVIG or steroids, or in certain forms with biological like rituximab. Or if it persists beyond 12 months, we call it chronic ITP. In that case, splenectomy is usually the answer. If you've got normal platelet counts, you should be thinking of qualitative platelet disorders. And remember, the very first thing is to see if there is any history of antiplatelet medication use like aspirin or clopidogrel. If not, then you have to go for von Willebrand factor studies to see if the child is suffering from von Willebrand factor. If that is normal, you have to go for platelet aggregation studies to detect if the child has got other qualitative platelet disorders like Bernard-Soulier syndrome or Glanzmann thrombocytopenia, which can be diagnosed based on these platelet aggregation studies. So this was in a nutshell how we work with platelet disorders, and how do we further sort of classify and differentiate between various causes which can cause platelet problems. So I hope you have learned something from this lecture, and if you have learned something, give me a thumbs up, share this lecture with your friends, and if you haven't subscribed to my channel, please do subscribe. And if you still have got any questions, comment, or queries, put it down in the comment section below, and I'll be more than happy to answer your questions. So have a very good and nice day. Take care and bye bye.